Start off, I'd just like to acknowledge all of our sponsors, not only for what they do for us and helping to, position themselves with our CE efforts, but for what they do for the dental sleep medicine community. All of their appliances and tools of the trade and the different devices they make available to us, and they keep upping the game constantly so that we can do a better and better job. And I'm very appreciative of their efforts. Fully digital workflow for dental sleep medicine, Dr. Suresh Sharkande. It's happening next week on Friday. Hope to see you there. And the next one after that will be anterior midpoint soothing stops with Dawn Malaysia, May 12th. And, we're going to see how long this shutdown goes and how long we spend time at home. And we'll probably be adding a few more webinar series, Corona webinar series, seminars, or webinars in the coming weeks after that. Dental Sleep Medicine Speakeasy online meeting room, Wednesday afternoons, 3 to 5. It's a place to come to discuss dental sleep medicine in an evidence-based manner, and we've been having a lot of fun. This will be our third session coming around tomorrow afternoon. A little bit of housekeeping before we get started with today's webinar. Audio options, select computer or phone, follow the instructions, and lower down you can see there's a little chat box area where you can submit your questions. Okay, you can actually make this panel disappear by pressing that little arrow at the top. And if you raise your hand, then that will bring your profile to the panelists' attention, and they'll respond to you. CE certificates will be emailed out in the next few days. This is our second webinar, so we're just sort of getting to know the routine. Please make sure that you do provide me your AGD number if you want to have AGD qualifying points, and this week we'll be preparing those certificates for this webinar along with last week's webinar with Dr. Barry Glassman. So today, does medicine have it covered with PAP? Why physicians need dentists with Dr. John Remmers? Well, what can I tell you about this gentleman? First of all, really, he was amongst the first people in the medical community to put sleep medicine on the map. He was amongst the first to elucidate what actually happens in the airway in the medical literature. He was involved in bringing to market the first home sleep test equipment. He was involved in the process of creating the APAP and bringing CPAP to an APAP type of environment. And then he was involved in creating the MATRx, the in-lab MATRx, helping to bring dentist and physician together. The other thing that he was involved in is porting that over to our hands in the dental world, in our offices, so that we can best use this technology and best help the patients. There has been no other physician that has played a bigger role in helping to create the footprint of dental sleep medicine and oral appliance therapy. There's been no other physician that has tried harder to encourage the collaboration between physicians and dentists in helping patients with sleep disordered breathing. And I'm honored to consider him a friend, and I'm so pleased to have him presenting today. And thank you very much for being here, Dr. Remmers, and take it away. The control should be in your hands.
Great, John. Thank you so much. It's great to be with you, folks. I'm going to give you a presentation from the pulmonary physician point of view, sleep physician point of view. I'm very dedicated, as John mentioned, to dental sleep medicine, but I think it's I can play a role by telling you how the physician on the guy on the medical side actually relates to your activities. So went too far there. I have a big conflict of interest. It's mammoth. I'm part owner, chief medical officer of a company, Zephyr Sleep Technologies, that makes this MATRx that John referred to. We call it MATRx Plus now for use by the dentist to predict how his therapy will go and to guide his or her therapy. So more about that later, but let's go on now. Here's where I begin. To advance, I'm going to do that. I'm having trouble advancing right now. Come on, let's go here.
John, if I put the cursor right over the
okay, maybe I need to click on it again.
I've got the cursor right over the arrow, so if you just click, it should advance. Don't move it. There you go. Okay.
Okay, there we are. Okay. Thank you. Okay, we've gone gave away my good stuff here. Just published in Lancet last year, a great medical journal, so you can believe all of this. About 1 billion people worldwide have sleep apnea. Huge number. Okay, staggering number, much bigger than we ever thought of. The other important thing is 85% are undiagnosed. So the clear message here is that we need to do something to increase our game to diagnose people with sleep apnea. For diabetes, another chronic disease, only 45% are undiagnosed. Still not good, but a lot better than sleep apnea. And for high blood pressure, another chronic disease that has cardiovascular implications, only 15% undiagnosed. So we're way an outlier here with sleep apnea. A massive amount of people, and almost all of them undiagnosed. That's the message. Here we have my hero, and I hope to make him your hero, if he's not already, William C. Dement. He's the father of sleep and sleep apnea, but let's just call him the father of sleep. And he has this quote that I want you to register very carefully with. Sleep apnea remains the most undiagnosed deadly problem in medicine. Wow. Let's start at the end. It's in medicine. So he says right away, hey, this is a medical disease. Make no doubt about it. Okay, check that box. It's a problem in medicine, deadly problem in medicine. So he's saying we got some big consequences of sleep apnea, and it's the most undiagnosed of these deadly problems that remain that are in medicine. So you got it, okay? It's a medical problem which is deadly and massively undiagnosed. Thank you, Bill. Now we're going to look at the evidence that says that this is a deadly problem. It's from the Wisconsin Sleep Cohort, and you've probably seen this, but I want to review it with you because it's so important. I'm plotting on the x-axis time in years, 20 years, and on the y-axis, the percent of people that survive. Well, what's going on here? Well, at time zero, 20 years ago, the people at Wisconsin recruited 1,500 workers in the state, randomly recruited them, and did polysomnograms on all of them. And then that was it. They didn't tell them you got sleep apnea or you don't, anything about that. They just said, thank you very much for having a polysomnogram. And then they divided the people up into those who had no sleep apnea, AHI less than 5, mild, moderate, and severe sleep apnea. And they just watched what happened over the 20 years. Actually, they did polysomnograms again at 6 and 12 years and 18 years. And you can see up here at the top, the folks with no sleep apnea, they're doing pretty well. 5% are dead in 18 years. But by contrast, those with severe sleep apnea are moving along pretty well too, until they get out here at year 12 and then fall off the cliff and start dying like flies. And at 18 years, we've lost 45% of people. They're gone, they're dead. So the difference between the upper line, no sleep apnea, and the lower line, severe sleep apnea, let's call it, 40% of people. That's an excess mortality of 40%. And it's graded It's less for moderate and less for severe. So this is wonderful data, and it's matched by more wonderful data from the sleep heart health study. This is the Framingham study, the famous heart study. It began about 15 years ago, started to include folks with regard to sleep. And again, at 0 time here, we recruit now 6,000 people. They're somewhat older, so they're going to die faster. So don't worry about that. But we include 6,000 people and study them again at 6 years and then at 12 years. And we're just looking at survival probability. This is still just the percent that died. And up at the top in this line here, no sleep apnea. Okay, now we're down to about 15%, since this is an older crowd. 15% are dead in 10 years. And the severes, you can see them moving down. And out here at about 10 years, we're down. We've lost about 25%. We're down at about 75% survival. So again, we have a substantial excess mortality attributable to sleep apnea. And I really want you to focus on the yellow line, actually. That's where the miles are. And I'm going to say this is 5 to 15, but I'll use the mean. Let's call this the average here is 10 AHI. So an AHI of 10 is clearly associated with a risk of dying, a fatality risk. Whoa. So that actually becomes the definition of the disease sleep apnea. That's the upper limit of normal. Take, for instance, how we decided that a diastolic of 90 was the upper limit of normal for high blood pressure. They did exactly this, and it's exactly the same kind of study, the Framingham study. It simply measured blood pressure and watched people in time. And it turned out that if you had a blood pressure where the diastolic is greater than 90, you were in a group that had an excess chance of a stroke. So you had a risk of a stroke, and that really says, okay, we're not going to be happy if the blood pressure's above 90. That's high blood pressure, we'll call it. That's the definition of high blood pressure. Something where the risk is apparent for a stroke. Here it is again. Here's a risk of dying, and it occurs, say, with an AHI of 10. So I'm going to define the disease as an AHI of 10, and I think that is fair. People have pushed to lower it to 5. Don't worry about that too much. It was mainly done at the behest of the CPAP manufacturers. They wanted to sell more CPAPs, and so if they increased the diagnostic rate, that would be in their favor. And so they pushed for reducing it to 5. But a value of 10 is a very reasonable value, and we'll go with that for today. This is then a serious medical disease. Can't doubt that. Serious implications, fatality amongst other things, and we must take treatment seriously. We must not be cavalier about the treatment because we're dealing with something that has fatality as its endpoint. Well, so serious medical implications when the AHI is over 10, that's just my premise today. And physicians are responsible for diagnosis and management. That's my other premise. You may disagree with both of those. You can turn off if you are, because those are for me facts of life that must be accepted. That it is a medical disease, and we have an AHI value at which we start to call it sleep apnea. And our goal in treatment is, of course, to get rid of sleep apnea. Let's look at history a bit. And this, John alluded to this. 20 years ago, we were still doing one way of diagnosing and treating sleep apnea. It was a polysomnogram, the in-hospital test, followed by another night, or maybe in the same night, slap the old CPAP pressure on there, put the mask on, and titrate, that is to say, increase the CPAP pressure until all the sleep apnea went away. That was what we were doing. And it was fine, except that it's not going to take care of this enormous reservoir of people that have sleep apnea. We need more convenient simple testing. So we came up with a home sleep monitor. The pushback from the physicians was enormous. They thought we were going to take away their polysomnograms. We're not. We need the polysomnogram, but we need more testing. So finally, 20 years later, I think we're now made some progress, and home sleep testing is a viable option. And we also then came up with an auto CPAP, which allowed the titration to occur under the guidance of a computer embedded in the machine here in the home. So now we can do a home diagnosis and a home titration and take care of it all without ever going into the polysomnographic lab. So it's now a better standard of care. We have a more convenient approach, faster, and a better patient experience. Have to tell you, there was enormous pushback on both of these. And both of them have been out there for about 20 years, and it's really only recently that we now can say this can be a standard of care. Now, to come back to the definition of the disease, I've noted that it's not arbitrary, it's not negotiable. It's based in two wonderful clinical studies. So we can't make up our own definition of therapeutic success. We can't say, oh, well, I like an AHI of 15. No, sorry, that isn't going to work. We're not going to, over here on the medical side, we're not going to tolerate that. Oh, well, I want a 50% reduction. No, sorry, that doesn't work for me. I want to get rid of the sleep apnea. Oh, maybe I just want partial treatment. And I say, loud and clear, we can't accept partial treatment. You're leaving the person with sleep apnea still at risk, and there's no medical evidence that will support the acceptance of that approach. We can't leave our patients untreated. The goal of the treatment is to eliminate sleep apnea. And I've told you what sleep apnea is. What about this partial treatment? Because people are really in favor of it today. They call it the effective AHI. And they say, oh, well, if you get the AHI down into some range, I don't say 20 from 50, the patient's better, right? Maybe, maybe not. We don't know that. And well, at least he's going to use it every night because this is efficacious treatment. This is a compliant treatment. Maybe, maybe not. There's so much we don't know. So this idea that we leave people with partially untreated and is unacceptable. The dentists who prefer partial treatment options, I'd say, incur a liability and risk. So I'm worried about that. I wouldn't do it if I were you. I lost that one. Where'd that one go? Oh, decisions regarding management of the disease also lie in the sleep physician's domain. So I would emphasize that it's not up to the dentist who's practicing dental sleep medicine to decide, oh, this AHI of 20 it's good enough for this fellow. Maybe, maybe not. But it's the physician who is trained in dealing with systemic disease. He's trained in that. That's what we're brought up to do, to worry about the interaction of breathing and heart disease during sleep, to worry about the long-term consequences of a drop in oxygen. These are things that we're brought up to do, that we do every day. That's what we learn in medical school and residencies and specialty training. So I wouldn't try to preempt that if I were you. I think that is clearly the domain of the sleep physician. But it's up to the sleep physician to work with a therapist. The sleep medicine dentist is the therapist. He's applying the therapy. Together we achieve effective treatment. Okay, let's talk about why 90% of apneics today receive CPAP and not oral appliance therapy, OAT. Let's talk about that. Why is that? Well, I'll lead off. I'm going to tell you, I rely heavily on CPAP sometime. I'm actually not a heavy user, but I'm pretending I'm the sleep physician here. I rely heavily on CPAP. Why? One is it always works. This is very, very, very important. You have to understand this. I love something which I can prescribe and know that it works. No doubt. I don't have to worry. That's a very important asset of CPAP, which oral appliances in the past have not had. The treatment protocols are understood and offer standard practice. I have a company down the street who's just like the drugstore, providing the CPAP. In that company is a respiratory therapist. I relate to the respiratory therapist. They're highly skilled people. They have my trust. They're going to carry out the therapy in a standard way that I know about. There's no black magic here. No. We have a standard approach. But there are problems with CPAP. Let me tell you about them. One is, this is very important, it doesn't do what I want it to do. What do I mean there? Well, often what I want CPAP to do is to eliminate the risk of heart attacks and stroke. And that's generally in my agenda of what I want the therapy to do. Well, it turns out that recent clinical trials show that in people without symptoms, no sleepiness, who have severe and moderate sleep apnea, if you prescribe CPAP, you're not going to reduce the chance of having a heart attack or a stroke or atrial fib. It's not going to do that. Beautiful randomized clinical trials published in New England Journal of Medicine. It won't cut it for those patients. Now, I said those are asymptomatic people, but I deal with asymptomatic people all the time with severe sleep apnea. So I don't like that about CPAP. 2, it spreads airborne infections such as COVID-19. I'm going to tell you more about it, but aerosol, there's a constant flow of gas into the mask and out the mask exhaust port, and it's spewing droplets all over the environment. I don't like that, particularly right now. Finally, it consumes energy all night, every night. I don't like that either. I don't want to have CO2 in the environment. Okay, what about COVID-19? Let's get serious about this for a moment. The coronavirus is transmitted by small droplets very, very, very effectively. So it's airborne aerosol, and it's incredibly infectious. So that means a few droplets going out from that mask or from a sneeze, if there's somebody around, they're likely to encounter this airborne aerosol, and in there is a very, very infectious virus. CPAP has been implicated in the spread of COVID-19 in long-term care institutions. That was in Seattle, the Kirkland outbreak in Seattle. And patients currently using CPAP, though, should not stop the therapy. I'm not in any way trying to say that somebody who's really well-tuned and using CPAP beautifully every night with severe sleep apnea should stop the therapy. No. Keep that going. Go back to your doctor and talk about it if you like, but don't just stop therapy. And then I want to note that CPAP machines can be used in hospitals if there's a medical grade filter attached to its exhaust flow. So it's the stuff flying out the mask that's important, and you can filter that, but that's not suitable for home use. You need to have a change of that filter quite regularly, and that will preclude its use in the home. Well, CPAP now is not recommended for new cases of sleep apnea. That's not recommended by the American Academy of Sleep Medicine, the Association of Anesthesiologists, and the British Thoracic Society. They all say don't do it because you can spread the disease by the aerosols coming out the exhaust flow. And then I know that oral appliance therapy is a pretty effective alternative to CPAP that does not spread aerosols, but it must be done right. I would like to say oral appliance therapy is the equivalent of CPAP, but it's the equivalent only if you do it right. And I'm going to tell you what I mean by doing it right. So the key question here that I have no answer to, but I just want to raise it for your concern, is that we need to decide how are we going to help long-term care facilities reduce the airborne infection for residents from residents who use CPAP. And this is a big deal. So we have people in a confined space, in a residence, or on a aircraft carrier, whatever, who are using CPAP. They get the coronavirus, they're asymptomatic, and bingo, everybody's got it now. So that's a problem that I have no answer to, but I just raise as one that you're going to see discussed a lot in the next few months. What are the problems with oral appliance therapy? Dentists often pretend that all patients respond therapeutically, that it gets rid of sleep apnea for everybody. Well, the physician, on the other hand, says it'll never work, but it does work. It doesn't work in all patients, that's for sure. That's the other problem that I have with oral appliance therapy as currently done, and the conventional methods, is that there's no standard of practice that's been established. By established, I mean it is based upon evidence that's been published, good clinical trials, and that has been reviewed by societies and say, this is the way you ought to do it. In fact, everybody got their own protocol. They do bite registrations at different positions. They start the protrusion with a custom appliance at different position, blindly, all of it's blindly. They had no idea where they're going to end up. So I don't like that. It makes me uneasy. Like, what's this dentist over here going to use? And why does he use that approach? So in many cases, sleep physicians don't trust the therapist, the dentist, because of this problem. So I say dentists must gain the trust of the sleep physician. Not that all of their referrals are going to come from a sleep physician, but needs to have the trust of the sleep community. And that then will mean that referrals will come, and we can start to make inroads on the fact that only 5% of people with sleep apnea receive the treatment that most of them prefer. So we have a problem, and the fundamental problem, I think, and the fundamental kind of obstruction to new dentists moving into the field is the problem of gaining the trust of the sleep community, the medical sleep community. Well, I'm going to change gears now. I'm sure that has riled a lot of people, but it's what I feel. I'm speaking from my gut up until now. Now I'm going to tell you about some data. I love to talk about data. Here, I'm going to give you results of 302 patients with sleep apnea, all of whom received oral appliance therapy, all of them. So it's actually a convenient sample of 302, and they occurred over 4 clinical trials. So each one, it was about 80 each. So this is the reason I'm putting together a bunch of well-controlled NIH level, FDA level clinical trials. Here's what I'm going to show you. It's a distribution plot. On this y-axis is just number of patients, okay? The total is 300, but this is divided. We're going to divide them up now according to how much protrusion was required to treat the patient, and that is to get rid of the sleep apnea. That's to get the AHI or ODI, the oxygen desaturation index, below 10. So this is how much protrusion was required. You can see it's quite different. It goes over the whole spectrum from 10% all the way up to 100% of protrusion. That's the efficacious position that I'm showing you here. And over here on the right, beyond 100%, we have the non-responders. 84 or 25% of people, we protruded them to the maximum and no therapeutic response. That is to say, the AHI and ODI were greater than 10. So this is one group over here I'm saying, whoa, I can't deal with them. But the rest, they're all individual. Look at this. It's not one size fits all. Some need only 10, 60, 100%. So look at that. So when you look at a patient, you might say, oh, well, I know this guy's got an AHI of 100. He's going to be over here. Wrong. I'll show you a case that's absolutely wrong on that. That guy with an AHI of 117, he needed 50%. And it was only when he was down here that he had a successful response. So AHI doesn't, baseline AHI doesn't predict where you lie on here. BMI doesn't either. There's no simple clinical feature that you can use to decide where the efficacious position is going to be. Similarly, you could think about, I'll look at the cone beam. That's a great measurement. Or, I don't know, a pharyngometry. I'll look at something else that's going to tell me about the size of the airway while awake. Ooh, sorry, it doesn't predict at all either. So you must dispel the notion that using clinical features and imaging that you can make a prediction of whether or not the patient's going to be over here in the red, a non-responder, or in the blue, a responder, and that you can predict where you will be on the scale of protrusion. Okay? You can't do it that way. You have to do a test during sleep. But I'm going to first talk about why do we have failure with oral appliance therapy. Well, let's have a look at that. There's several reasons. First one, we may be dealing with a non-responder. Doesn't matter how much you protrude the patient. 25% in my studies overall are not going to respond. Okay, I can't get rid of the sleep apnea with an oral appliance. Well, it's nice to know about that in advance and not undertake treatment in those patients. But what else? Let's assume that we're going to start here. I'm going to say 70%, and the conventional method is where we begin titration with the custom appliance, and we move the mandible out and wait for an aha moment, and you know all of that, which I think is all entirely bogus because it's not based on any evidence at all. But anyway, let's say we start here. It's a very common place. Well, turns out that of the blue patients, the ones who are going to respond, half of them will respond at protrusion, which is less than where you start. So you've over protruded these guys. Over protruded. And you might say, well, okay, I don't really care too much about that. Well, maybe you're going to have some symptoms that are unnecessary, but I'm going to show you some cases that have a paradoxical response to protrusion, so that if you move a patient here and protrude them out to maximum, you can actually see therapeutic failure. So you may be missing the whole boat on people when you start over protruding them. And then we have the other group, of course, out here who may not tolerate the treatment because you've pushed them so far. And you might like to know that in advance, how much protrusion is going to be required. So you can plan and discuss it with a patient. In this group right in here, I've got 55 patients right in here. They're going to be just fine. But it's a minority of the whole patients. The whole population of patients here, of 300 patients, minority are okay if you just begin right at 70% of full protrusion. So I say that the way we do it conventionally is got a problem, and we need to fix that problem. So how do we avoid these treatment failures? Well, it's by treatment planning. I don't think that's new to you, and it probably doesn't surprise you that I would say treatment planning is important. Here's what I mean by treatment planning. We have awareness leading to diagnosis, leading to treatment planning. And this is a place where the therapist will customize the treatment to improve or optimize the outcome. Then we go from treatment planning to treatment to follow-up. But this is the key step. This is the key step. This is where we're going to actually determine outcome largely. Here's how the key thing is, though, the treatment planning requires two things, two types of information: valid information and predictive information. So I want to do the treatment planning before I undertake treatment, obviously. So it must be predictive. That's hard. Prediction is tough. And it must be valid, means shown to be give accurate predictions in rigorous clinical trials. All right, here's how we do it with CPAP over here on the medical side, and why I like CPAP so much. Same idea, awareness, diagnosis, and then we go to an auto titration study. The respiratory therapist puts the patient on auto CPAP for days or a week or two, and that auto titration, it's an automatic titration that occurs during sleep. The data is recorded and out comes an optimal pressure that I should use for this patient. Then the therapist selects the correct interface, and away we go. Treatment, CPAP treatment, and then very importantly, follow up to see if the patient is adherent to therapy. But this treatment planning is key here. It's done by the respiratory therapist, and I trust her to do it exactly, or him to do it exactly the standard way. What about oral appliance treatment? Well, we can do the same sort of thing. We can have MATRx plus titration. It's an auto titration study, exactly the same as a CPAP auto titration study. This is going to be MATRx plus, and instead of moving the pressure higher and lower through the night to get rid of the sleep apnea, we protrude and retrude the mandible through the night. Pull it out, push it back while the patient is sleeping. And we record what happens to the sleep apnea, and we can then select an appropriate protrusive position and select, and then that is followed by a selection of the appliance by the therapist, by the dentist, and we're on our way to correct oral appliance treatment, and we do treatment follow-up. So there's an exact parallel, and that's what the physician expects. I mean, I can't say it any other way. That's the way we do business. That's the way we wanted to do things. So here are the keys to your success as a therapist, in my view. First of all, carry out treatment planning before you treat. So get it together and decide how you're going to plan the case. Deploy methods that are clinically valid, evidence-based, and FDA cleared. That's all. Use that. And then you'll gain the trust and respect of the sleep physician. This is what he expects. This is what he cares about. He knows what's going to go on over there if you do it this way. Well, do we have a treatment planning method that's valid, evidence-based, and FDA cleared? Yes. Yes. One. Right now, one. There are going to be more, hopefully, but right now there's one method, and I call it the MATRx Plus device, and it accurately predicts who and how to treat. I'm going to show you the predictive accuracy in just a moment, but that's what it does. It's a home sleep test that involves moving the mandible in and out during sleep, and it will predict. I'll show you a case or two. But first of all, let's look at the accuracy. Treatment planning requires accurate prediction of whether or not the patient will be a success, or prediction of whether the patient's going to be a failure with oral appliance therapy. So before we undertake the therapy, let's find out how it's going to work out. Here's baseline. So I'm going to look just at those who are predicted to experience therapeutic success. This is from our latest clinical trial. We have three clinical trials like this, and I'm plotting the oxygen desaturation index here. I like that because it's more stable and has better predictor of long-term risk than AHI. So I'll use the ODI, and at baseline, in the predicted success group, from 10 up to 117, and all of them, when we go to outcome, that is to say we put the custom appliance in the mouth, we have a ODI less than 10. The mean value is 8.5. All of them, no exceptions. Everybody we predicted to be successful turned out to be successful. Now over here, predicted failures. Again, we're plotting the ODI here at baseline, similar distribution of values at baseline. With outcome, though, it's quite different. all these red ones, changed very little, if at all. So they were failures. They had very poor response to oral appliance. 4 of them were incorrectly predicted to be therapeutic failures. So this is not a perfect method, but it's a lot better than nothing, or than using the AHI or the BMI or something like that. So, but this is incorrect predictions here, 4 out of the total. And we say this, and the 28 is the mean value of all the predicted failures. Well, pretty good stuff. What about predicting the efficacious position, telling the therapist how far to protrude the mandible? Well, it's shown here. Here's the predicted position at which you will get a favorable therapeutic response. Okay? This is the predicted position by the results of the MATRx Plus test on the x-axis. On the y-axis is what actually was the efficacious position. How much did you have to protrude the patient's mandible in order to have therapeutic success? If you lie on that dashed line, that means they were equal, that the predicted value was enough, and you had efficacious response to the custom oral appliance at that predicted position. Well, in 85%, it worked out just fine. In 15%, we were under protruded a bit and had to move out a couple of millimeters. That's these up here. So 15% of the time, you need a bit more protrusion, but you're in the ballpark in everybody, and you actually only and are perfectly spot on at 85%. So I say, I'm closing now, that this is all about patient experience. I think you would agree that your goal is a favorable patient experience, and that has a number of dimensions that I want to refer to. Decrease the time to treatment, spend less time off work, increase the productivity of the patient, sleeping better sooner. I mean, as a physician, I love that. Second, it's about confidence. Confidence actually of the dentist, but then people having confidence in the therapist, in the dentist. So the confidence on the part of the patient and on the part of the referring physician. So it's key. Confidence is what we're all about, and confidence arises because we can carry out treatment planning based upon validated, accurate data. And then finally, we think you'll have better treatment adherence. People feel more comfortable with it, more confident all about it, and they will take to the treatment better. Now, in terms of efficiency, obviously, if you don't have to blindly adjust a custom appliance over a period of months waiting for an aha moment, that's what we conventionally do right now, well, you're going to be more efficient because, in fact, only one visit is required after you do the treatment planning and you make the appliance. And that's the visit to insert the appliance. That's it in 75% of people, one visit. So you'll be able to treat more patients. You'll save money from unnecessary titration visits. You'll increase your overall production. And the key here of all of this, key is to drive referrals from the physicians because you've demonstrated excellence and patient experience. That's the key thing. The patient's happy, you're going to get more referrals. You can know that everything will turn out well, and everybody's happier with that. So we think that in the most key dimension of your practice, getting referrals, that this is very important. I'm going to show you just one case, and then I'll finish. It's a 46-year-old male whose normal body habitus, ODI, oxygen desaturation index, with nothing in the mouth, diagnostic was 117, came to us on an oral appliance, maximally protruded, and had an ODI of 34. Whoa. Here's the study that was done, the MATRx Plus study. And I just will have you look at the top here. That's the mandibular position. It begins at rest position, comfortable position. It's moved out and back and out and back. by the body-mounted computer throughout the night. So this is a home study, and it's everything's applied by the patient. And then on the next night, it's a 2-night study. On the next night, the mandible begins again at rest, and then is protruded out over a half hour to an initial preliminary target efficacious position, and then adjusted a little bit beyond that. So we did that. This is a standard 2-night study from the MATRx Plus. And what did it tell us? Remember, this guy has a baseline AHI of 117, or ODI of 117. Well, it says he's a responder. Well, we already had him. He came to us at maximum protrusion and still had severe sleep apnea. This doesn't make any sense at all. That's scary. And says he will be a responder at 50% of full protrusion. So here we are between habitual and max. Put him halfway along there, and it says you're going to get a response. Well, we did that in a follow-up study, confirmed the efficacy, showed an ODI of 1.7 at 50% of full protrusion. Well, that's scary and totally not counterintuitive. Really what it's doing is it's showing us the importance of what we call high loop gain, high sensitivity of our system, of the control system that's controlling our breathing. And it just emphasizes that you cannot imagine that we're dealing with some simply a floppy tube called the pharyngeal airway. It's much more complicated than that. That floppy tube, the airway, is embedded in an overall system that has feedback controls, that has arousals, that has muscles that are active by the chemical stimuli and by arousals. So it's a very complicated system. We've studied it all. People are still studying it, but we know a lot about it. And suffice it to say that you can't simply think of this as a system that has a narrowed airway, and if you protrude the mandible, it's going to expand the airway. It may do that, but that doesn't say that it will, that always when you expand the airway, protrude the mandible, you're going to get a lower AHI. You may get a higher AHI. Okay, here we are. Here's what I want, or what I don't want. I don't want my patients subjected to guesswork, uncertainty, out-of-date clinical practice. I'm just speaking as this sleep physician over here. That's what I don't want, and I don't really like the prolonged titration. I like starting people right away on CPAP and knowing that they're fixed. That's what I call a bad patient experience. I don't want that. I refer patients exclusively to dentists who are well-trained and who use validated treatment planning. That's all. I want that. Just like I have it for CPAP, that's what I want for oral appliance therapy. And with that, I'll say MATRx is the only way to provide that. It is. You can take it from me, but go to the literature. There is no other way that you're going to get a method for predicting outcome and for telling you where an efficacious protrusive position is for a particular patient. So everything else, I call it dark art. Dark art, all I mean is it's not validated. It's based upon somebody's clinical experience, and great clinicians. They've been doing it for years, and they might be shocking the scalp, or they might be listening to you talk when you protrude, or they might be seeing if you can snore. Or another one is Goldilocks. It's my friend Jameson Spencer uses that. He likes just set the mandible where it's very comfortable, and that's the good place to start. Hell, I don't know. He doesn't know. Nobody knows. Nobody knows. MATRx Plus is the only way that you can accurately be informed about the treatment that's required. So give me a call if you like. I'm sitting around confined to my condo, and there's nothing I'd rather do than talk to interested dental sleep dentists. Thank you very much.
Fantastic, Dr. Remmers. That was wonderful. And we're going to be taking some questions through Elaine. But before that, just a bit of housekeeping. It's about 10 to 2 right now. John, can you stick around a little bit longer if the questions go beyond that?
Love it. Love it.
Okay, so we're open-ended on this end, but for those of you that do have to leave it too, that's no problem. Just make sure that you answer the couple questions at the end and provide me your AGD number if you want AGD qualifying points, and you're good, you'll get your CE points. And those that want to stick around, Elaine's going to be fielding the questions to Dr. Remmers, but I want to start off with the first question, John, please. You spoke about the COVID issue and the Kirtland nursing home. And I understand that Myers actually published in April a new little concoction where he's put together components that can be added to PAP so that improve the filtration, make it more of a closed system, although it'll never really be a closed system. I'm going to take it another place though. What about the mask itself? Even if we use good filtration and so forth, mask leaks are a known issue with PAP, and even as per ResMed, it's not whether there's a mask leak or not, it's the degree of the mask leak. So as long as it's an acceptable amount, then it's okay. So maybe that's fine with regards to therapeutic benefit from PAP. But the question I have for you is any degree of a mask leak acceptable when you're dealing with an infectious situation like COVID-19?
I can give you my opinion. We don't have hard evidence about this, but what we have interface leaks between the skin and the mask, but we also have leaks out the mouth. So this gases continue flowing out the mouth in lots of folks, particularly in an old folks home. You might find people who have, the lax jaw. So no, we can't have any of that. It's all provides a risk. The droplets come spewing out, and they're going to get spread around. Now, you don't know how, and I want to caution about the idea that you can, take care of this by adding a filter. I don't think so. I think the filter that is suitable, that will do the job, does the job when you change it regularly, daily, and it can be used in the hospital, but I don't think it's suitable for institutional use or home use, or use on the aircraft carrier. I believe that, so I think we'll see, but I think CPAP will always have this, for nightly use in the home, will have this high exhaust flow. So overall, we have a problem. I'm not saying people shouldn't use CPAP, please, that's not my point at all. I'm just pointing out the problem, and there is an alternative that I think is very important to consider. And so we're going to learn more, John, but at the present time, it's enough of a problem that the leading associations and societies say, don't use it. Don't use it. Don't start people on this right now. So if we're going to come out of this in a month, we're going to be back on the street, going to places, and people will be knocking on the door of the CPAP company saying, I want to have a CPAP. And they'll do a test, and maybe they'll say, you have sleep apnea, we'll start you on CPAP. Well, maybe we want to think about that. Maybe we don't want to do that. We're going to be in a very delicate period of months, maybe a whole year, when we're still worried about infectious spread of this incredibly infectious virus. So I think we're gonna do a lot of talking about this over the next few months.
Thank you, John. Okay, Elaine.
Okay, so we actually got a first question from somebody very eager just before the webinar started. His name is John Boozy. I hope that I pronounced it okay. It says, good morning and thanks for what you do, Dr. Remmers. Should there be a time at the end of the presentation, I would like to ask the following. Dr. Remmers, first, let me say that both those that suffer with SPP and those that deliver care will forever be grateful for your innovative thoughts and contributions. I can only imagine it has been a very challenging yet worthwhile task. The question is, having been a long-time believer and follower of the MATRx technology, shortly after the in-lab device became available, I approached the 3 sleep labs in our community. There are now but 2, and none of the 3 had awareness of the device And once that was provided, none of the three were anywhere near interested in providing that service. Fast forward to the present. Within the last 18 months, I have made contact with 3 pulmonologists boarded in sleep, one in New Jersey, one in Colorado, and one in Wyoming, none of which had any knowledge of the MATRx Plus. And once information regarding the diagnostic, theranostic, auto titration research, and binary predictability of the device was provided, none would move forward with considering the studies in order to provide LOMNRx for either PAP therapy or appliance therapy. The science and the technology are there, but without a clear pathway to practical economic implementation. Can you provide any advice or suggestions as to how to make that occur? Thanks so much.
Well, thank you for the
That's
compliment.
a long question.
To start with, thank you so much for the compliment. But let's get right to it. This is very important stuff. So we don't do anything that's not evidence-based. And first of all, it was mentioned that there's a diagnostic component to MATRx Plus. You can use MATRx Plus for diagnosis as a home sleep apnea test. The evidence that that's accurate, it's FDA cleared for that, and the evidence that it's accurate is in press. Like it's a week or two away from being published in Journal of Clinical Sleep Medicine. So you will have that publication. That's the publication of the diagnostic accuracy. Now let's turn to the theranostic test, the test that predicts outcome. So not diagnosis anymore. We're going to predict outcome. And here we have one published study. The MATRx study in lab was published, but now we have an in-home device, MATRx Plus, and that was the accuracy of that prediction has been validated and published in, again, the same journal, Journal of Clinical Sleep Medicine. A second clinical trial has been done, and it's right now in review in the journal Chest. So we have 2, and I can send you that manuscript. If you'll just give me let me know that you would like that, I can get you the manuscript that is in review. But it shows very similar predictive accuracy to the first one. So we have now 2 clinical trials on the in-home predictive test. And those 2 trials are actually based upon another study of 130 patients where we trained the artificial intelligence. So I think we have something that's very good, very solid, and I showed you the data from the last clinical trial, the most recent clinical trial. Your more general flavor is, how are we going to change the world? We got something that works. How are we going to change the world to start to use this? And here, sadly, I do not know the answer. I'm just a simple inventor. I just make stuff and try to make something that's useful. So I've made something. I think it's useful. I'm hopeful that somebody will find it useful to change our current therapeutic practices so that we can provide patients an option. That's all I want to do. I just want them to have an option of one treatment or the other. They're both good treatments. Decide which one you want. I'm in favor of both of them, but I think in order to get widespread clinical acceptance of oral appliance therapy, we're going to have to make them equivalent. We're going to have to show the science, and we're going to have to put it right in the face of the pulmonologist and sleep physicians you were talking about. So I will help you do that, actually. You come to me, I challenge you. You come to me and tell me whom you want to present this evidence to, and I'll write an email and include the attachments, and it'll go right in their face. I'll do it. Because we need to challenge people. I think we also have another problem internally on the dental side. I don't think we have enough thought leaders who are willing to put this forward. Fortunately, John is a great one. He puts me forward, allows me to express this. But I think you'll find a lot of courses, quotes, for dental sleep medicine, and they really emphasize and demonstrate and encourage the conventional dark art, I call it, the blinded method, and because that's the way they practice, and that's not an unreasonable thing on their part. They're the thought leaders. They're the top sleep dentists around, and they get lots of referrals, mainly CPAP failures. And so on a CPAP failure, they say, well, I'm just going to put this appliance in here and do the way I know how to do it, and everything will turn out all right. Well, I don't know that it does. What I do know is that that's not an approach that's viable for lots of dentists who are practicing dental sleep medicine. It's not. And to be able to get established in the community and have the referrals coming from the people that you just mentioned, we're going to have to do better. And this is a way to do better. Thank you very much for that insightful question.
Okay, so next we have Alexander Mayer, who joined us, and he actually has a comment. He said that Dr. Remmers is polarizing.
Maybe, yeah. I have no idea about that.
Okay.
There've been no attempts on my life yet, and actually, I think I've got lots of friends. I really do. That's part of my personality. Is nobody that I know doesn't like me now, but I'm polarizing. Well, so I can tell you that I feel very strongly about this, more strongly than I did about anything else that I've done. And the reason I feel strongly about it is that I realize it's not easy to change the patterns of practice. People do what they do. Look, I was practicing too until a year ago, so I don't practice anymore. But people do what they do because it's convenient, it works for them. They go into clinic every day. That's what they do, and they do it well. But not necessarily if we say, well, that's the way it's going to be done forever, then we've just consigned ourselves to mediocre care. The only way we're going to improve our care of patients with apneics is diagnose more and treat more, but in a better and better way. And MATRx is a first step, as far as I'm concerned, in the theranostic game. People tried the theranostic study before, and you may say I'm polarizing, and they thought that a CT scan would be just the nuts, just the greatest. Well, it didn't work out. I'm sorry, it didn't work out, and it's not my fault that it didn't work out. So I'm not polarizing about that. All I'm saying is the truth. I'm saying that if you try to use clinical features or imaging while awake, you will be disappointed, because the studies that are done prospectively by people like Peter Sestouli say that it's no good. Let me give you a direct quote from Peter Sestouli. A couple of months ago, I said, you've done all this work for the past 10 years on trying to prospectively predict outcome with clinical features and imaging, and what's your feeling about it? He says, it's been deeply disappointing. 10 years of work, and this is the world's greatest investigator in the field. It's been deeply disappointing. Translate that into, it isn't going to cut it. It doesn't provide the accuracy that you need. So maybe I'm polarizing, but I'm saying what I know, which is, and I don't think I've said anything much that's not evidence-based. Try me out on that too. And I don't mind people who are polarizing and speaking from a base of evidence. I don't like people who are maybe saying stuff that you would consider non-polarizing, but but basing their comments and their outlooks and their feelings, beliefs on stuff that's not true. That bothers me, honest. I don't like it.
Okay, so Alexander Mayer also has another comment. I agree with John Remmers about different titration protocols and starting positions. The question of trusting the dentist is a central question in therapy. Now, there's another comment from him. 25% of non-responders is a fair quote. And again, Alexander's here. I absolutely agree in the need of prediction. That's how the physicians work. We do not have, we do have to predict treatment outcome. The better the adherence is, sorry. The better the adherence is, the better the overall standing of oral appliance therapy. It's, I'm not really sure what he was trying to write, but it's a Q thing, I guess. And then low loop gain, not high. Then we have a comment from Dr. Barry Glassman.
Wait, Dr. Mayer, though, that was a lovely comment, and I think he's being very thoughtful, and there's a lot of steps that we don't know about. There's a lot of uncertainty. This is just a beginning, and I can tell you, for instance, that it now looks like we'll be able to predict outcome based upon the results of a polysomnogram. Nothing in the mouth, but just doing what we call the phenotyping of the patient with regard to the various characteristics that determine the apnea-hypopnea index. Whoa. And it won't be long before that can be done in the home, because we will now be able to certainly be able to do sleep staging in-home tests. So the idea that we're going to be always relegated to guesswork about the appliance, whether it's going to be useful or not, I think it is clearly wrong. So this is a start. Other data that's being gathered during sleep. So this is the key thing I want to emphasize. You have to get the data during sleep right now, as far as I know. But other data gathered during sleep, like polysomnographic data, looks very encouraging that it can also predict outcomes. So that's out of Wellman's group. Sestuli's a part of it. Danny Eckert's a part of it. Great investigators. So stay tuned. And they may put me right out of business, which is just fine with me. All I want to do, though, is get this ball rolling and get some good investigators working on it. Thank you very much, Dr. Mayer. I very much appreciate your thoughts, and love to chat with you. Give me a call sometime.
We have Dr. Barry Glassman saying, John, you are aware, I'm sure, of the studies that suggest achieving an AHI below 15 does not improve the potential to protect from CV accidents. How do you feel about adding more information into the decision as far as who is defined as a responder?
Right. So Barry, that's a wonderful question, and it's becoming the focus of many really high-class investigators now. Is how can we go well beyond just a responder, non-responder? Can we predict the level of AHI? Can we attribute to or ODI? I'll stick with ODI right now, since that's the more predictive. Oxygen is the more predictive variable. But it's very important to recognize that it may make a difference in risk if you have an ODI of 10, 20, 30, and so on. Or it may make a difference if you're using a dip in saturation for your ODI criterion of 2% dip in saturation, 3, 4. you can get different results. And the lead worker on this is Naresh Punjabi at Hopkins Sleep Heart Health Study, and he's the one who says ODI is a better predictor of cardiovascular risk in uncomplicated sleep apnea. In complicated sleep apnea associated with heart failure, then it's time less than 90 that predicts how long you're going to be around, how long before you die. So time that your oxygen saturation is less than 90 is the predictor there. And the best, the other one that's really quite almost amusing to me, but I'm sure it's got some truth in it because it comes out of Punjabi, is that he looked at what the association of sleep apnea with chronic diseases is. The three he used were diabetes, stroke, and myocardial infarction. So he said, let's see how they're associated when I use different cutoffs for the desaturation. So he said, okay, I'll run all my data, and this is 6,000 patients, and he knows what happened to each one. So he says, we'll do the ODI, we'll make the ODI being a dip of 2% and see what happens. And when you use a dip of 2%, you'll pick up the diabetics. You'll have a correlation or a prediction of the diabetics by the ODI. But if you then, but not heart disease, if you add desaturation to 3%, so 2 and 3, whoa, then you start to pick up strokes. And it's only when you use desaturation to 4% do you pick up all three: strokes, diabetes, and myocardial infarction. So whether that's all going to hold up or not, I don't know, but it's a very interesting approach, and it gives you the idea that of great interest right now is to try to understand what parts of this spectrum and measurements that we have are going to predict what types of outcomes. I think that's basically all Sestuli works on these days. So our leading investigator in the world, he works just on this.
Barry also says that he considers being called polarizing a compliment. Just saying.
Yeah, I thought so too, John. I thought so too, actually.
Well, thank you, Barry. I've learned from the great one there, and from you, my friend Barry. Thank you, buddy.
Now we have something. Hi, Greg, from Greg Vogel. Those numbers are respective to patient's edge-to-edge position.
Say this again. Say the question again.
Those numbers are respective to patient's edge-to-edge position.
Oh, body position, maybe. Is that what he's asking?
No, he's probably thinking about protrusion.
Protrusion.
Edge-to-edge protrusion. I'm thinking that's what he's thinking. Yeah.
So I don't really understand the question. So we're thinking of now protrusion and.
Okay, John, I think I may have some insight here. With your measurements, John, I think I may have an insight here. Your measurements with the MATRx Plus go from full retrusion to full protrusion. So the percentage would be along that range. Greg is referring to, habitual protrusion to full protrusion, what would those measurements be? Along which range?
Yeah, it is habitual, or it is our estimate of centric occlusion.
Okay, so it's from centric occlusion to full protrusion is the percentage of going forward. And so,
Suresh, you're going to ask Suresh about that in the future. But yes, that's what it is. Okay. And so it was against Alan Lowe's advice. Alan said, no, it's got to be full retrusion to full protrusion. But we thought, look, we're never going to be retruding people to treat their sleep apnea. So let's just talk about the therapeutic range and keep it simple, and maybe that'll have some effect. So yes, John, we did that from the beginning. And I don't know. I think Barry thought it was okay. Anyway, that's what we do.
Right, so Greg's referring to edge. I'm not quite sure what he's getting to with that question, because you don't really even consider whether it's edge to edge or not. Some people might be at class 2.
It was actually, sorry,
I'm sorry.
Dr. It was regarding measurements of target position.
Right.
It is. So the 0 on the scale is edge to edge. That's George Gauge type standard stuff. So 0 is edge to edge. You can have, the one case I showed had minus 0.8. So 0.8 millimeters behind was the habitual or rest position. And then there's a max position, which might have been 0.6 in that case, which might have been 6 millimeters. So the edge to edge is just the reference for us. And we're looking at protrusion, and then we express the percentage as the value along that scale. Okay.
From centric height, or the closest centric height to full protrusion?
Right.
Right.
Okay. But I want you to just, you're going to hear a pro about this, and be sure to follow up and ask him in detail about it.
We'll follow up with Suresh next week.
Yeah, I think it's important that I don't say something stupid here.
Okay, so the next question is from Jim Rodriguez. Since matrix HST is post-diagnostic, HST or PSG from physician, how is the matrix HST paid for? Will insurance cover this treatment planning procedure?
Wow, who's paying for the Matrix Plus? I have no idea, and that's going to have to be worked out on an individual basis. I assume so. So the answer is I don't know. It's a big problem, perhaps, perhaps not. But I can only say I don't think what we do in Alberta is relevant to the answer there. In general, we think that the cost of the HSAT, the diagnostic test, is going down. It goes down to 0 right now in Calgary. So it's not like the price of oil, which went negative, but it's 0 in Calgary today. So you can go in anywhere and get a HSAT done for free in Calgary. But generally, that's likely to be paid for by the insurer. But the Matrix Plus thing is a totally new approach, and will require some explanation to get insurance payment for that. We think that it will come. We will justify that, and that the efficiency, just the insurer not paying for appliances that are not therapeutic will be very helpful in that regard. I don't have any easy answer about this, and this happens. 20 years ago, certainly nobody was going to pay for the HSAT test that we brought forward. That was clearly a non-starter, but eventually it did get paid for. So I can only say I am not an expert about any kind of reimbursement. I believe that we are at a time when things are likely to change, given, I'll just put it this way, I think that CPAP's clay feet are beginning to show. Clearly the insurers know that adherence to therapy is poor. So to move to a new therapy that has much better compliance and that can be prospectively administered, I think will ultimately land us in their good graces. But good question, but I don't have any good answer for you, I don't think.
Thank you, Dr. Remmers. Price of oil was minus 46 in Ontario yesterday. So you're a little bit better off than us. So moving along Thanks for your very good, great and honest answer. I'll put together a short list of contacts to facilitate a conversation. That's from John Boozy.
Great, thank you, John.
Then we have from our good friend Lynn Raimundo. Hi, Lynn. Can Canadian dentists read their own MATRx Plus auto titration reports, or must it be sent to a sleep physician for analysis?
You'll have to help me say the question again. I couldn't quite get it.
Okay, so can Canadian dentists read their own MATRx Plus auto titration report? But must it be sent to a sleep physician for analysis?
Oh, it's a beautiful question. So let me say first a general, give you my general view about this. We moved from the in-lab test to the in-home test specifically to empower the therapist, the dentist. And we think that the purpose of this, I want to call it a theranostic test, or a test to guide therapy. That's what we mean by that. To facilitate treatment planning, that test is of use not to anybody except the therapist. It's not a diagnostic test. It's not an outcome test. It's simply a test to guide therapy, like doing a cone beam before you put some implants in or something. You have to have your therapy guided, and that's what this does. So we think if you didn't, that it is a test for the dentist. Now, should it be interpreted? I think not. I think it can be. It may be that the therapist wants to have, that the referring physician wants to have a look at the test. I think that's just great. If you have that kind of interaction with your referring physician, send them the results of the test and say, what do you think? How would you like me to proceed? And so on. But that's an option. It's not a requirement. So it's not a requirement that you have a physician have a look at this. You may want to. And again, like a cone beam, you might want your radiologist to have a look at it. But the prediction is made only upon this test, nothing else, no clinical features, no imaging features, just the results of the test, and it is an automatic prediction. So I think that there is no requirement for the physician review. I think it's a great idea. I think it would really facilitate the acceptance and enthusiasm on the part of the physician if you can share this data with anybody you want to, it turns out. So you could have a sleep specialist, we'll call him, and bingo, he'd look at it, and then you and he could discuss the case together. I mean, you can see all kinds of things on the theranostic study. You can see that you have emergent central sleep apnea or emergent high gain behavior with increasing protrusion. That was the case. That was what happened in the case that I showed you. So you can see this. You can see that as you protrude more, sometimes you see increase in the incidence or the rate of occurrence of respiratory events, of apneas and hypopneas. So you can see these paradoxical and unexpected things that will happen. You certainly can see central sleep apnea quite easily. These are things that can be shared. You can see inspiratory flow limitation that you and the physician might want to share and think about. All those are valid data. You can use them to plan your therapy, and there's nothing better than to plan the therapy in conjunction, that aspect of the therapy in conjunction with the physician. You, of course, bring a whole set of expertise that the physician doesn't have. You understand the mandible, you understand the joints, and most importantly, you understand those teeth. So clearly, if you can have that interaction, it's the basis for everything. It really makes the whole treatment process hum.
Okay. We have.
Lane, there was a comment that was made even right at the beginning, right when we first started the broadcast. So
Yeah.
that should be right at the beginning. Maybe you can share that with Dr.
We already shared it, Dr. Lee.
Oh, did you? Okay.
Yeah, we did. That was the second one after you.
Okay.
So, what about using the MATRx Plus for determining the mandibular position for a young orthodontic class 2 patient who has sleep disorder breathing? That question is from William Farrell. Oh, sorry, William Harrell.
Yeah, I'm going to leave this really to Suresh, but
Okay.
we had lots of class 2 patients in our clinical studies that I showed you, and the predictive accuracy remains 85 to 90%. So it's not a problem. But I'll leave all of that to Suresh. But there's not a limitation at all on what we do.
So there was no relationship, John, between the habitual posture position of the patient, whether they're class 1, class 2, or class 3, and how well the MATRx, work.
I don't want to say no relationship, but I can say it's not a limitation. Okay. So our simple approach is I'm not going to say this correctly, but it's the overjet. It's the edge to edge minus the overjet is basically what we use. It has to be very carefully measured by the dentist, but it's our fairly objective way to get the rest position.
And that's it.
Okay, well, listen, John, Dr. Remmers, thank you so much for a wonderful, wonderful presentation. We had the majority of the attendees that logged on originally still here, right to the very end.
Well, I love you all, is what I want to tell you. I love you all.
We truly appreciate
I'm dedicating my life, what's left of it, to you guys and your whole effort. So that's where I am, and it comes right from the heart. And good luck to everybody. Stay healthy. Stay alert to the possibilities here during this the COVID era. It's going to be quite interesting. So just stay alert to those possibilities.
Absolutely. Appreciate your presentation today so much. And I'd like to end with sending out a heartfelt thank you to all the medical personnel, everyone in those front lines, right from the bottom all the way to the top, the boss. Thank you so much for what you're doing. I mean, our job is to stay home, stay away from this, and stay as safe as possible. We're so appreciative of all the efforts you're all putting in. Thank you so much, and consider visiting next week on Friday when Suresh Sharkinde is going to be talking about the digital flow, and the questions that didn't get responded to today, he can respond next Friday. Thank you so much.
And Elaine, thank you for your help as well. Thank you, John.
Of course. Thank you, Elaine. Thank you, John. Thank you, Callie.
Thank you.
Bye-bye.
And don't forget when you sign off to answer those few questions so you get your CE points. Thank you so much. Bye-bye, everyone.
Okay, bye.
Thank you.